All right, continuing on with chapter 35. So, talking about changes in the gastrointestinal system. So, just overall, there's a reduction in the volume of saliva, which then results in dry mouth. You have kind of overwhelming dental loss in the older population, which then contributes further to nutritional and digestive problems. Gastric secretions are reduced, so oftentimes you get more indigestion type symptoms. Changes in gastric motility leads to slower gastric emptying. Um, there's a greater incidence of diseases that involving the bowel, and then blood flow to the liver ends up declining, enzyme activity decreases, leading to impaired liver function, and part of your liver's job is to help digestion. So some pathophysiology, those age-related changes within the GI system can lead to a number of different problems, but GI bleeding is one of those in particular. It can be caused by inflammation, infection, or just obstruction, either in the upper or lower GI tract. Signs and symptoms kind of vary depending on where it happens. You could have coffee ground-ish or darkened stools. You can have vomiting with blood in it. So it really kind of depends on where it's at. But either or can be life-threatening. Kind of depends on how bad it is. Other specific GI problems that are older and common in older patients, diverticulitis, GI bleeds, both upper and lower, peptic ulcer disease, gallbladder disease, and then bowel obstruction. When we're talking with patients in the geriatric population, we definitely want to ask about their NSAID or nonsteroidal anti-inflammatory drug use, and then alcohol use as well. It's nice to ask about Tylenol use, since Tylenol can affect the liver as well. So any sort of over-the-counter meds they take tend to be very pertinent to what's going on with them. Orthostatic vital signs can help determine if a patient is hypovolemic, or can just show you that there's a decrease when they go from a laying to a seated to a standing position. An acute abdomen, this is kind of non-gastrointestinal complaints that lead to abdominal pain. The most serious threat from abdominal complaints is blood loss, which can lead to shock and then can lead to death. The most rapidly fatal condition is a AAA or an abdominal aortic aneurysm. Depending on where it's at, it will manifest in several different ways. The lower it is, the more likely that it will manifest in low back pain. The higher it is, the more it's going to present as just straight up abdominal pain. For the renal system, age-related changes to the kidney include just an overall reduction in renal function, a reduction in renal blood flow, which is what leads more so to the renal function, tubule degradation, so just breaking down over time. Urinary system, decrease in bladder capacity, decline in sphincter muscle control, which leads to varying degrees of incontinence, as well as decline in voiding senses. That leads to incontinence as well. An increase in nocturnal voiding. Nocturnal voiding just means that you end up having to get up in the middle of the night to pee because of the decrease in capacity. Benign prostatic hypertrophy. This means men are the only ones that have a prostate, so it starts enlarging for no real particular reason, but your urethra goes right through that, and so as it begins to enlarge, it starts putting pressure in on that urethra, which can make it very difficult to urinate normally. Incontinence is definitely something that is a natural part of aging, but it ends up leading to skin irritation, breakdown, as well as urinary tract infections, um, all tying back to the decreased capacity of the bladder. You can also have the opposite of incontinence, which is urinary retention or difficulty urinating. It could be because of bladder UTIs that cause inflammation. Um, if it gets bad enough, you can actually have patients experiencing renal failure, and oftentimes they're going to need assistance in order to empty um, their bladder fully. Changes in the endocrine system. Um, Oftentimes, the biggest one is going to be a decrease in metabolism of thyroxine, which then leads to hyperthyroidism. Thyroxine affects the body's metabolism, temperature regulation, growth, and then heart rate. So, what you end up seeing in patients that have this is a slower heart rate, fatigue, drier skin and hair, and inability to tolerate the cold weather, and then weight gain. You can also have what's called hyperosmolar hyperglycemic non-ketotic syndrome. For short, just call it HHNS. This is a complication of patients that have type 2 diabetes, more so than the type 1. So oftentimes you're going to see signs and symptoms similar to diabetic ketoacidosis, except you don't produce ketones. That's the difference in this. The patient's still going to present with signs of hypotension and shock, including tachycardia, because they are still going to be severely dehydrated, but they're not actually breaking down that glycogen to try and raise their blood sugar because they don't need to. And so you don't get the ketones, but you get everything else. The blood glucose level will be variable in DKA, but when we're talking about HHNS, the value is typically going to be higher than 600 milligrams per deciliter. DKA presents with Kussmaul respirations, HHNS doesn't, so a couple of different symptoms there. Changes in the immune system, aging kind of makes you more susceptible to significant infections. Many older patients don't end up developing a fever, so they end up not being able to fight infections as well because that's your body's natural way of preventing bacterial growth. Oftentimes, the patient can have a severe systemic infection and actually be hypothermic instead of presenting with a fever. Anorexia, which in this case just means that they don't eat as normally. It's not the way you would think of somebody consciously starving themselves. It's literally just they don't have an appetite. So anorexia, fatigue, weight loss, falls, changes in mental status may end up being the only primary symptoms of an infection. It may not be the I feel terrible, I have a fever, that sort of thing. Pneumonia and UTI are very common in patients that are bedridden, that have less mobility. But when an infection occurs, signs and symptoms may be decreased, may be minimized, or may just be completely missing. So don't rule an infection out based on that. Musculoskeletal system, aging brings a pretty widespread decrease in bone mass in both men and women, but postmenopausal women are definitely at the most risk. Bones end up becoming more brittle. They tend to break more easily with a lot less force. Discs between the vertebrae of the spine begin to narrow. You have a decrease in height between 2 and 3 inches, and that can occur throughout the lifespan. And then you also tend to get postural changes as well. Joints end up losing their flexibility, maybe further immobilized by arthritic changes, so inflammation of those joints, and then a decrease in the amount of muscle mass often result in less strength overall. Changes in physical ability can affect a uh, geriatric patient's confidence in their mobility. They have declines in strength. The ligaments and cartilage of the joints lose their elasticity. Stooped posture often leads because of atrophy on the supporting body structures. Osteoporosis leads to a decrease in bone mass, which then leaves our patients with a greater susceptibility to fractures. And once it happens to them the first time, that tends to give them a little bit of a almost PTSD because they realize how easy it was the first time and they just don't want that to happen again. Osteoarthritis is kind of a progressive disease in the joints. It destroys cartilage, promotes the formation of bone spurs in the joints, which then leads to stiffness. Most often is going to affect the joints in the hands, knees, hips, and spine, but truly can happen at any joint within the body. Patients often complain that pain and stiffness get worse with exertion. So it tends to not be as bad in the morning, but as the day progresses, definitely gets worse. Changes in the skin, the proteins that make the skin flexible and pliable start to decline. The layer of fat that's underneath of the skin becomes thinner because of redistribution of fluids and those proteins. As the elasticity of the skin declines, patients tend to bruise more because the skin ends up tearing more easily. Your exocrine or your sweat glands don't respond as readily to the heat because they have atrophied, and then you end up just getting overall changes in the dermal layer of the skin. Pressure ulcers are pretty common. Just the weight of the body over a bony area can actually cut off blood flow to that area, and eventually you'll end up getting sores because the skin will start to break down. To prevent pressure ulcers, you want to try and put pads under bony prominences and voids, especially for patients that are immobilized for extended periods of time. You may see what are these decubitus ulcers is what they're called in various stages of development and healing. Decubitus ulcers can be extremely painful. They can cause complications such as bleeding, sepsis, and then an inflammation of the bone called osteomyelitis. Toxicology, older people are more susceptible to toxicology from their medications because of decreased kidney function. The kidneys end up clearing a lot of our medications. So if the kidneys aren't working, it's going to stay in their system a lot longer. Altered GI absorption, and then a decrease in vascular flow to the liver. Same thing, the liver tends to clean out a lot of what we put in our body. Decreased liver function makes it harder for the liver to detoxify the blood and eliminate substances such as medications as well as alcohol. Over-the-counter medications can have negative effects when they're mixed with each other or with the massive myriad of medications that the geriatric populations tend to be on. A lot of people are under the assumption that over-the-counter medications are not dangerous. That's why they sell them over the counter, but that's not true, especially if they're mixed with several other substances. A lot of our geriatric patients tend to be polypharmac or polypharmacy, which means you end up having several different types of prescription medications just for one patient. They're on several different drugs at the same time. And negative effects can include either overdosing or medications interacting with each other. Medication noncompliance is definitely a huge deal with older patients, can be because of financial changes, inability to open their containers, or impaired cognitive, visual, and hearing ability. We'll go ahead and stop here and continue on in the next.